narrow canal, hard disc, multi-level pathology, and how do I decide what surgery should I do? What do you want as a spine surgeon? You want a happy patient and you want good outcome. Do whatever. Patients are coming to you for good outcomes. They want to be happy. There is a big enigma and they don't want to have surgery, all these things said and done. Most of them will have conservative trial and non-surgical management. Yes, because the fear factor is there, and therefore we are seeing in this MISSABCON everyone is talking about less and less, and I don't know what is the short form of again less, because everyone is trying for minimalistic endoscopic surgery and whatever possible, and that's going to happen. At the same time, we need certain cases where we need to stabilize as well. So this is a case. This patient is with multi-level affection, 3, 4, 4, 5 and 2, 3 foraminal disc multi-level, degenerative scoliosis, significant back and leg pain, difficulty to do daily activities. Is a retired teacher. I normally ask patient, what is your expectation from me? And this patient told me, doctor, I want to explore India. I didn't go to any place much in my entire career. And also I want to do Char Dham Yatra. I said, okay, fine. And because of this, I am really suffering and I tried so many things for last 2-3 years. He had no deficit per se. And this was how he was walking. He was listed completely. And we planned for a surgery. For this, we did multi-level decompression, less invasive. If you see in this X-ray, the midline is intact. We did not disturb the facet, the midline, no laminectomy. And in less invasive approach, we did stabilization and we fixed it from D12 to L5. And this is a 3-year follow-up of the same guy. And he came back to me with neck pain after doing his Char Dham Yatra. So I think that is what every one of us are here. And these are the routine cases which we normally see in our practice. 2-level disc, what should I do? 1-level disc, 1-level listhesis, and all these questions are there in our mind. Whatever experience you are, maybe 10 years, 5 years, 20 years, always every patient will be new and he will ask some different questions. When you think, how do I approach this patient? Whether I should consider conservative treatment, blocks, should I consider surgery? He's already been there, surgery, and then what surgery levels, single level, multi-level, whether I should consider endoscopic, microscopic, MED, or open surgery, mini open surgery. All these things are always there. But last but not the least, we should think about what surgery will give me the best outcome. This was a very interesting paper which we came across for this talk, where 47% presenting with degenerative disorders have multi-level pathology. Natural history suggests 32% will improve with conservative, 55% will remain unchanged. So that is itself is a 87% of very big number for these patients. And it's important to decide when to operate, how much to decompress. And again, all these gadgets we are seeing from yesterday, minimalistic surgeries, microscopic, tubular, open, MIS. First and foremost is clinical examination assessment. It's not the MRI or X-ray, but clinical examination. The levels, the affection, any amount of reduction in dysesthesias, any dermatomal distribution weakness, any myotomal weakness. These are very, very important. And this is again a paper which talks about, this was a very interesting paper which talks about single level laminectomies are better in functional outcome than 2-level laminectomies. Surgical time plays a big role, and 85% of adverse events have occurred in surgeries which are more than 3 hours. Endoscopic UB surgical time, as per this paper, is around 90 minutes. And if 2 to 3 levels to be operated, if the time is going more than 3 hours, lot of complications are expected, including wound adhesion, superficial skin infection, and so on. Again, site of pain. Some patients will have both side pathology, and the disc can be, one disc can be on left side, the other disc can be, 3-4 is on the left for foraminal compression, 4-5 is on the right side, central and paracentral for compression. And this was our paper, which is, we have published is analogy of lumbar disc, residual, recurrent or retained disc. And this paper we spoke about the recurrent disc. Normally we always, when we do a surgery, if the patient is coming back, we always say this is a recurrent disc. When someone else's patient comes to us, we think probably it is residual, is not done a complete job, and that's always in our mind. And it's nature and it's human, but retained is something which is supervised neglect. And what is supervised neglect? If there is a L4-5 disc, we thought the root is free, disc is quite contained, but it is bulging, but I will just keep it, keep patient will get better. Most of the time it works well, but sometimes that disc comes to you again in 1 or 2 months, and that's a retained disc or supervised neglect disc. So we need to be very careful for assessment of these patients. This is a patient of 35 years, back and leg pain significant, right-sided extrusion, done everything, not better. And this surgery was done, the tubular discectomy and this microscopic decompression surgery and very small incision, patient did well. 75-year-old man, back and leg pain, leg was more than back. Again, his expectations were to get better for walking. 2-level decompression surgery was done with endoscopic surgery. You can see we did a hemilaminectomy with endoscopic surgery where 3, 4 and 4, 5 both were addressed. It's seen in the X-ray very clearly, and this patient is doing fine because there is something like a auto stabilization. There is a natural inherent body mechanics which helps you to keep your body stable. We have to respect the stability. ALL is there, discs are there and facets are there, which really will help you for keeping the integrity. This is again some cases less than 2 levels. Can you do endoscopic? Yes, you can do endoscopic surgery after the assessment, and single working channel for 2 levels. You can do it. You can change your trajectories and you can actually assess. We use the navigation for these surgeries where we can do over the top bilateral routes and everything becomes very easy.
The L5S1 also is looking nicely decompressed. I'm going to the inferior part, and 4-5 and 5-1.
And this is the beauty of these newer gadgets. We actually can do 3-level job with endoscopic surgery. Again, certain cases like this 65-year-old man, back and leg pain. Only decompression, is it the answer? I think in certain cases we have to be very selective when to fuse. As Dr. Kulkarni just now spoke to us about fusion, that's very, very important. Symptoms, instability, all things will dictate about the level which you want to fuse. Sometimes we feel like fusing 4-5 and keeping the 5-1 as it is. And this is all endoscopic cage placement.
Very important.
And navigation really can tell us exact placement of the cage, accuracy of your screws. Therefore, you are not worried most of the times in post-operative period. Patients can be mobilized the same day or the next day as per their pain. And the other post-operative imaging for multi-level. And a lot of patients who will come to you with narrow canal, where we need to consider all these different modalities will work for you. Decompression is the answer because lumbar canal stenosis is a disease. It's a mechanical compression where we need to consider decompression. And as we are doing endoscopic surgery, we really can get the answer by doing endoscopic surgery, and 1, 2 or 3 levels also can be done for narrow canal, and you really can get a very good visual magnification and decompression. And the beauty of UB is that you can do over the top opposite side very, very comfortably once you get acquainted, and we assess it always with navigation. Navigation is like our big brother in the theater. It tells us how much level we have decompressed.
Please
how
summarize.
Much, yeah. And this is the last hard disk where we need to understand if the disk is pressing significantly. If the bump is quite significant, we need to take the hard bump. Bumpectomy is important, and you can use the small osteotomes or some instruments whichever you are comfortable. And in case of instability, again hard disk and instability, we need to fix it. Thank you.